Welcome and thank you for joining us today for today's fireside chat, insights into the interconnection of cardiovascular disease and maternal morbidity and mortality. I'm Dr. Irina Ninye, the Chief Science Officer for the Society for Women's Health Research. SWHR is a national nonprofit dedicated to advancing women's health through science, policy, and education while promoting research on sex differences to optimize women's health. I would also like to thank today's sponsor for today's event, Amgen. SWHR maintains independence and editorial control over our program development, content, and work products. For those tuning in live, we will be tweeting during this event and invite you to use the hashtag SWHR Talks Heart on all social media. So we've changed up our format, our regular format today, as we are broadcasting this program live from the National Conference for the Nurse Practitioners for Women's Health. I'm here at SWHR's booth 422 in the exhibit hall. So if you're watching this and at the conference, stop by, say hello, and pick up some women's health resources. In fact, we have a very special guest with us today. Sitting next to me is Heather Maurer, the CEO of MPWH. Welcome, Heather.
Thank you so much, Irene. Thank you so much. And thank you for being here and being part of our conference. We're now in our 27th year of holding our annual MPWH Women's Healthcare Conference. We have over 25 CEs throughout the 4 days here on topics ranging from everything from period equity to perimenopause and menopause. But we also have specific tracks related to women's health nurse practitioners and advanced practice registered nurses and their scope of practice in taking care of folks who are pregnant, as well as courses on cardiovascular health, risk assessment, and really helping bring our providers and clinicians that are here the latest and greatest evidence information. And for those who can't be here in person, all of our sessions will be available online after the meeting, about 6 weeks after. And so you'll be able to listen to the sessions afterwards. And Dr. Connie Graves was on earlier this morning, so you'll be able to hear that panel, as well as many others who are super well versed and greatest scientists bringing us the latest evidence.
Great. And so what are you looking forward to the most with this meeting?
Well,
I know you're busy.
I'm just a little busy. You know, this is the accumulation of the latest and the greatest, as well as an opportunity to bring the community of women's health nurse practitioners and advanced practice registered nurses who provide women's and gender-related healthcare together. And so we have a record attendance of over 925 people here, which is super exciting. And it's a great opportunity for networking, learning, and giving yourself some time to fill your bucket and also bring back to your practice, you know, golden nuggets of clinical expertise to bring about change, equity, access, all of those great things that we are all working towards.
And so you've heard it right here. This is a premier conference for nurse practitioners for women's health. And this is the woman who runs the show.
Thank you, everyone who's here. And we hope to see everyone next year in Vegas. So we'll be celebrating our 45th anniversary next year.
Wow. Thank you so much, Heather, for stopping by. Looking forward to it.
Well, thank you so much for having me. So good to see you.
Good to see you as well. All right. So cardiovascular disease is the leading cause of mortality and morbidity in the United States. It is a major risk factor for severe maternal morbidity, or SMM. SMM affects approximately 60,000 women in the United States annually, and rates continue to increase, especially amongst certain racial and ethnic populations of pregnant people. Pregnant persons living with the combination of heart disease and a pre-existing chronic health condition are at increased risk of maternal morbidity and mortality. That's why prompt diagnosis and treatment of CVD are vital to reducing potential adverse pregnancy outcomes. Preconception screening and counseling, as well as continued monitoring during pregnancy and postpartum, can help recognize and mitigate cardiovascular-related maternal health challenges. We are pleased today to have a distinguished guest speaker for this event, maternal fetal medicine specialist, Dr. Cornelia Graves. Dr. Graves is a medical director and managing partner of Tennessee Maternal Fetal Medicine, and the medical director for perinatal services at St. Thomas Health Systems. Back in 2014, she joined forces with cardiologist Dr. Stacey Davis to start the Collaborative Perinatal Cardiac Center, a joint venture between the two institutions. This center was one of the first in the nation to address maternal heart care from the preconception period through postpartum care with a focus on long-term prevention. We are excited to have Dr. Graves share her expertise as we engage in this important discussion about the risks and impact of CVD on maternal morbidity and mortality, highlighting clinical interventions that could improve overall health in women. Dr. Graves, welcome.
Thank you.
As we enter our discussion today, I invite everyone tuning in live to use the Q&A function to submit questions throughout the event. We will try to answer as many questions as we can during the discussion portion of the latter portion of this program. But please note that our conversation today is intended for educational purposes and not intended to serve as a substitute for medical or professional advice. We encourage all patients and caregivers to confirm information and consult their healthcare providers to determine their individual needs. So to open this conversation,
Yes.
Dr. Graves, I want to take a step back and do something a bit foundational. We always hear the term maternal morbidity and mortality, but what does that mean to a layperson? What does that mean?
So maternal morbidity is the injuries that can occur during pregnancy or in the postpartum period. For most people don't know that in the United States, we actually count not just your 9 months of pregnancy, but that first year. And it's defined as a rate of per 100,000 people. So when we talk about morbidity, we talk about the injuries that can occur, such as renal failure, such as the need for long-term support. Often women who may have neurological damage to where they have a stroke or other long-lasting complications that can affect them in some way, not just during their pregnancy, for that's lifelong, or for several months. And then when we talk about mortality, we talk about women who die during childbirth or in the 365 days surrounding that time after delivery.
Oh, wow. And so I'm still wearing a bit of my global health hat. We just came back from the United Nations Science Summit program earlier this week. And despite being a high-income country, the United States is one of the highest rates of MMM. And cardiovascular disease, we know, is a leading cause of death in women. So together, these pose really serious challenges for women's health. And we don't really want to scare women, but we want to make them aware. And so that they can be equipped to optimize their health long term. From your perspective, what should individuals who are pregnant be thinking about? And even those that are thinking about becoming pregnant, what should they be thinking about as far as the risks or the impact of cardiovascular disease on their maternal health?
Well, I think the first thing that people need to know that the United States does have a high maternal mortality rate. We're somewhere around Zambia, actually, when you look at our outcomes. And if you look at outcomes for women over 40, or especially for women of color, outcomes can be even closer to that of Rwanda or the Congo, which should shock all of us. So some of the things that women need to think about when they're planning their pregnancy is, number one, do I have risk factors for heart disease? Take your family history seriously. Your mother had a heart attack at 45. That can mean that there's something, this just didn't happen, but there's something in your family that can cause issue. One of the most common things for young women is that they have high cholesterol, because high cholesterol can be, what we call familial or run in your family, but no one knows it because no one has checked your cholesterol. Also take into account those modifiable things you can do. Your weight, smoking or other substance use, whether or not you want, how close you want your pregnancies to be. And although we can always control our age that we get pregnant, planning when you're going to have your family can be very important. If you have underlying chronic diseases such as diabetes, or you kidney disease, or you have heart disease that you know that you have, then you need to go ahead and talk to your provider about planning your pregnancy around those and entering into a preconception period for your pregnancy so that the pregnancy is safer for you, but also safer for your baby.
You mentioned some of these risk factors that were either familial or even modifiable or through lifestyle. And so I know screening and follow-up care is very important. And once you said cholesterol, of course, it buzzed, hit a bell that SWHR, we have our Read My Lips campaign, which is Read My Lipids and getting that cholesterol screening. What other types of screening tests might someone want to request if they want to have that conversation with their provider?
Well, number one, you want to request your lipids. You want to request like your kidney function. A lot of women have underlying kidney disease, and that's just something they didn't know. Again, that can run in families. So those are some of the tests. You want to request a CBC or complete blood count. That can tell people, one, if you're anemic, which often we can modify before you get pregnant, because once you become pregnant, as I always tell my patients, they always worry about the baby not getting enough. And I'm like, no, the baby's going to take what it needs. You're the one that's not going to get enough. And so it's really important to make sure that you're in good health. And also in that complete blood count, you can look for things like platelet disorders. So we can kind of sort those out before. If you're having issues such as our family history of autoimmune disease, or you've had a history of blood clots or those types of things, you may want to ask for an autoimmune workup and a clotting workup as well.
Oh, wow. That's quite a bit. So who do they talk to? What type of providers can do this care? Is it their OBGYN? Is it their specialist? Is it cardiologist? Which providers would be the most knowledgeable to go to in these areas?
I think the first thing, if you're planning a pregnancy, is to talk to your OBGYN, and they can make the appropriate referral. As maternal fetal medicine specialists, we do a lot of preconception counseling because we're going to focus on every medical problem that you have, not just your heart, not just your diabetes, not just your kidney issue, but we're going to put it all together for you to give you a complete risk assessment. We think in our practice that preconception counseling is so important. We give a full hour. So you can answer your questions, we can go through everything that we need to go through, and then we develop a plan for you so that you can follow that plan, and maybe even follow up with us again prior to getting pregnant.
So, you mentioned something about gestational diabetes, and we know certain conditions can occur or develop during pregnancy or around that pregnancy period. Is this the same for heart disease? Are there any particular facets of cardiovascular health that can emerge during this time?
Well, preeclampsia is a cardiovascular disease. And we often don't think of preeclampsia as being a heart disease, but that is exactly what it is. So we know that women with pre-existing diabetes and pre-existing high blood pressure also have an increased risk of having preeclampsia and those types of issues. In addition, if you have, there's just certain risk factors that increase the fact you may have underlying heart disease, i.e. being of indigenous or African heritage, having a BMI greater than 35, using substances, and that is legal and illegal substances. As I always point out, smoking and alcohol affects your heart, especially in women. Having a history of chemotherapy. But you had breast cancer, you had Hodgkin's lymphoma, and you got treated, and then it's been 5 years, but that can also affect your heart. And then being at what we call advanced maternal age, somebody over the age of 40. And we have developed screening tools. In fact, we have a screening tool that we use in the pregnancy, during pregnancy, and in the postpartum period to help people identify those cardiovascular risks and whether or not someone has cardiovascular disease, because pregnancy often mimics many of the things that someone would have, for example, in heart failure, or someone would have if they have an abnormal heart rate. So we know that pregnant women are short of breath, they can't climb stairs, and often because of that, those things are dismissed and not worked on.
So what are other things you mentioned? I like how you said there's certain things that you have to look at because you have to notice. It can be hard because there's a laundry list of symptoms or presentations, and we know for cardiovascular health, they're very different between men and women, and so how much training goes into OBGYN care? I mean, training when it comes to heart health, pregnancy.
OBGYNs have some training, a little bit of training in preventative care, but they can also refer you to your cardiologist to talk more about your heart health. as a maternal fetal medicine specialist who has special training in critical care, I have extensive training in kind of identifying those patients who may be at risk. And as I said, we have come up with a screening tool that also helps your providers identify risk. And the screening tool we currently use, actually, we use it, it's in our EMR, is a hard stop. And so anytime you access the OB, ED, or OB emergency area, these questions are asked. Because we know that heart disease, you may be great, up to like 24 weeks, and then all of a sudden things happen. So anytime a patient presents, we want to re-ask these questions and take their complaint seriously.
So the monitoring is important. And something that you said that I just wanted to highlight is that even if you check, you should still be on the lookout throughout the pregnancy and each trimester and just continue to have the conversation.
Absolutely. As I said, preeclampsia is a heart disease. And so one of the things, I have a postpartum preeclampsia clinic in which we do risk assessment identification. And when I'm asking patients when they develop their preeclampsia, I'll ask, I said, did you gain a lot of weight, before 20 weeks to 24 weeks? And they'll say, yes. I said, did you get to a point where you couldn't wear your wedding ring? Yes. And so if we talk about weight gain in terms of heart failure, we have to talk about that in the same terms of developing preeclampsia as well.
I like how you put it into very practical terms. Can you still wear your wedding ring, or, where your weight gain or the time frame? Because those are things I think we might think about more. I can't fit my shoes, or, and they're very tangible for a patient to be able to identify whether or not if it's normal or if it's borderline or something that they need to raise a concern for. And so you mentioned something in some of these disparities. We see often disease disparities, of course, between prevalence between men and women, but then we also see this among certain populations of women. You mentioned with advanced maternal age. If you could speak a word of encouragement or advice to a couple different groups, I wanted to highlight. So the advanced maternal age, what would you suggest for them to do?
Plan your pregnancy. Get your chronic conditions under control. Counsel with your provider. If you have diabetes or things of that nature, know that having diabetes actually may increase your risk of birth defects depending on how high your blood sugar is. So you may need to be able to work with your provider to get that down and get yourself in the best condition possible. But then keep in mind that, there are a lot of women who have children after the age of 35. In fact, most of my patients are after the age of 35. And there are a lot of women who have children after the age of 40. So it's not impossible, but we do need to take a little bit, think about ourselves a little differently. I always point out that if you're 40 and you're getting surgery, you get an EKG. No one says, oh, we're just going to take her to the OR and put her to sleep and she'll be fine. So we have to think about those things when we're taking care of the pregnant patient as well.
And what about, you mentioned something, those that weren't here this morning, I was in the session that you were on the panel, about if you have a geographic distance, what can someone do to be able to get care if they're not in the city or they're not near a major comprehensive care center?
So the first thing is that you need to figure out where your center for care is and how far that's going to be. And then if you have significant health conditions, whether or not you can even deliver in that center, because there are maternal levels of care and health. So your rural hospital is probably not the place for you to deliver if you have congenital heart disease. So you're going to have to plan to deliver maybe in a hospital that's a little farther away. So that's the first thing. The second thing I tell people is to plan for transportation and those types of things. And then if you are comfortable with it, ask your provider whether they have telehealth options. We see our diabetics every 2 weeks, but in people who just to manage their glucoses. But for people who are not getting an ultrasound, we often offer them that one of those visits via telehealth, which then keeps them from having to drive 2 hours in. And so those are the options you can ask for if those are things that are available to you.
And then the other groups are maybe one or two that you want to, as far as racial ethnic groups, what disparities or information should they be a bit more aware of? to address?
So we know that there are disparities among almost all Black and brown women or birthing people in this country. So one of the things I always tell people is to educate yourselves. Know your body and know your signs and symptoms, and don't take no for an answer. So if you go in and say, I'm short of breath, and they say, oh, all pregnant women are short of breath, like, no, 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 this is really different. And someone is saying, say, I understand it's probably normal, but I still want to be worked up for this anyway. There's a great campaign from the CDC called Hear Her. So if you're not assertive, you may want to take somebody with you to advocate for you in the healthcare system. We also know that our Native and Indigenous populations who often don't have access to care can have poorer outcomes. But again, part of that is education, making sure, you ask those questions. Can I really deliver here in this health area? Or do I need to go to a university hospital to make sure I'm safe? And if I'm going to a university hospital, how do we work with that? How does that translate? Those are all the things that people need to know. Last but not least, we know that bias and discrimination occur in the healthcare system. If you're not comfortable with your provider and you feel like your provider is not listening, you may need to seek another provider. But so that until you feel heard about the things that you feel that are concerning you regarding your health.
And so, this is really good information for our patients, and we appreciate that. But I'm going to be the advocate on the patient side. Speaking to your healthcare colleagues, right? What advice would you like to offer for them to better understand all these nuances? Because you talked about location, you've talked about race and ethnicity, you've talked about age. What can they do to ensure that they're providing better healthcare if they're not aware? How can they engage in this way?
Well, first thing is to listen and to ask an open-ended question. So one of the things I ask my patients with diabetes is I ask about their blood sugars. And I say, well, how do you think you're doing? Instead of me telling them how I think they're doing. Because one of my patients said, well, I'm doing much better because my sugar was 400, Dr. Graves, and now I'm down to, to 300. And I'm like, well, that's great. We're still not where we need to be, but you're making progress. So always ask those open-ended questions. You seem to be late for the office for your appointments. What are your barriers to getting here, on time? You did not pick up, or you're not doing the diet that we asked you to. What are your barriers? I think it's so important to talk to your patient and figure out what their barriers are instead of just assuming, like we often do in healthcare, that the patient is willfully not doing what we ask them to do.
And so when we know that there is the association between CVD and maternal mortality and morbidity, what are some of the complications of heart disease that we should be looking out for? I know you mentioned the preeclampsia.
Well, we know that preeclampsia is a marker for cardiovascular disease, and those women should have longer-term follow-up. Patients with chronic hypertension, patients even without pre-existing diabetes, gestational diabetes is a marker for long-term issues. If your baby did not grow well in a pregnancy, that can be a marker. And patients with preterm labor, for no reason, they just deliver early. Those are all markers. And so when you see your PCP or your primary care provider, or you see your OBGYN, you just say, hey, I had these complications in my pregnancy. And then we can look at markers to see whether or not we need to fix your cholesterol, or do we need to adjust your insulin level. And there's a lot of work coming out about polycystic ovarian syndrome and its relationship to poorer pregnancy outcomes. Are those things that we can modify before we have our next pregnancy? So even though we may not know that we're going to have a poor pregnancy outcome the first time, it's also important, if we've had a poor pregnancy outcome, to get consultation and intervention before our next pregnancy.
And so, tapping back into some of the conversations we had earlier this week was about the maternal health workforce. And there's shortages across the board. We're lovely to be here at nurse practitioners for women's health. And so we've talked about OBGYNs, maternal fetal medicine. So there are definitely a breadth of individuals or healthcare providers that can assist in cardiovascular health in pregnancy and making sure that a patient's getting all that they need. What are your thoughts on how we can further strengthen this maternal health workforce in making sure that pregnant populations in different areas or different ages are getting that care?
So what we've done in Tennessee is we train our doulas. We train our doulas to go out, give them blood pressure cuffs. We train them to take blood pressures to recognize that the patient has preeclampsia or a pregnancy complication. That's one of because we can't go out. Most physicians and physician extenders are in the office setting. We can't, and if your schedule is like my schedule, there's no way one can go out and do home visits and see the 20 people or 25 people that are on your schedule. But what we can do is extend that, teach other people who interface with the community to identify these complications. The patient has high blood pressure and now she's short of breath. The patient has high blood pressure, she's gained 20 pounds in 2 weeks. Those are the things we have educated our doulas with in the state of Tennessee, so they're empowered to actually recognize some of these abnormalities.
I really love that. And while we're talking about CVD and pregnancy, what happens afterwards, right? Because the pregnancy is done, baby is there. Of course, they always say no one cares about mom anymore because the baby is about, all the attention is there. But what should a woman be thinking about postpartum? Not even just 6 weeks or after they do their initial checkup, but 6 months, 1 year, 2 years, 5 years after.
So I feel strongly that patients should be seen with adverse pregnancy outcomes in particular should be seen 8 to 12 weeks after they deliver. I cannot tell you how many familial high cholesterols I've diagnosed in that period. There's no reason that your triglycerides should be over 200, or your insulin level is really high. And I'll be talking about this some, but talking about all the things that you can do before your next pregnancy. One of the things that has may become our friend is the new weight loss drugs that can actually help not only people lose weight, but take care of some of these factors before they become pregnant again. Figure out when the patient wants to get pregnant. Talk about prenatal aspirin. You had a poor pregnancy outcome. And often, I want to just put a plug here to say that often patients who should have gotten prenatal aspirin for minor risk factors did not get it. The patient with her first pregnancy who happens to be African American, the patient with her first pregnancy who happens to be 40, they didn't get their prenatal aspirin. So talking about that and making those decisions about what you're going to do with your next pregnancy. Establishing them that follow-up with cardiology or with the kidney doctor or whoever you need to follow up with. So that you get that 6-month follow-up and that year follow-up. And while, some states have not expanded Medicaid, and I'm from one of those states, what we did expand is that be able to see your provider up to 1 year postpartum. So take advantage of that and making sure that, especially if you're going to plan to have another pregnancy, that you get those things taken care of. But even in those patients who don't ever plan to have a pregnancy, again, that you're plugged in for lifelong care.
So as we are planning to wrap up, I want to, we often have patients and healthcare providers as well as researchers and policy stakeholders that tune in and industry that tune into events like this. And so what is one final takeaway that you would like viewers to know that can better support and improve the outcomes concerning CVD and maternal morbidity for women?
Take the postpartum period seriously. You said it best. When the baby's out, everybody runs off and the mother is kind of left. Our maternal mortality in this country is mostly postpartum. It is not during the pregnancy and it's not during labor and delivery. Most of it is in the postpartum period. This is when women are going to develop their peripartum cardiomyopathy. This is often when women who have high blood pressure have strokes. This is the time period in which women come back in with complications. It is important to take the postpartum period seriously.
Thank you so much, Dr. Graves, for all this time. I mean, that's such key information. You have given us a wealth of info to think about and marinate moving forward, to be able to improve and promote and protect our cardiovascular health, especially during pregnancy. We really appreciate your time and your insight. And we also thank Amgen for the support of this event, and SWHR's Heart Health Program. We recently launched an advocacy toolkit for women's heart health that serves as a guide for to support efforts around CVD, including spotlighting actions to advocate for increased research investment in heart health care and equity for women's cardiovascular health. And you can download this and other women's health resources on our website, www.swhr.org. And I think they're going to put in the chat a link to this particular resource. We also invite you to connect with us on social media, sign up for our newsletter, and register for future events about endometriosis, obesity, menopause, and other topics. We will be sending out an email recording for today's chat to all registrants, as well as posting it on the event's website for future viewing. So please be on the lookout. Feel free to share that as we continue the conversation with SWHR Talks Heart. Thank you for joining us, and thank you, NWH. It's been a pleasure.
Thank you.